Dear friends, we are going to continue with a next debate, our next panel discussion, and we're going to look at a very important topic, right? Estonia's health insurance fund is running into, well, what I would call as a journalist, serious trouble. Perhaps there's a better way in describing it. The budget gap for next year is more than 200 million euros, and by 2027, I guess we might run out of reserves completely. Now, at the same time, we see that the state budget is under pressure, so there are no easy fixes. But perhaps we can turn this problem around and somehow find a good solution. So we're asking now in this panel, how can we rethink healthcare funding, not just to fix the gap, but actually to build something stronger and more sustainable. And to answer that question, I'm pleased to invite onto the stage the chairman of the management board, Estonian Health Insurance Fund, Rain Laane, and the Deputy Secretary General of Fiscal Policies from the Ministry of Finance, Sven Kirsipuu. Rain, first, what are your three top arguments to the Ministry of Finance when you meet Sven? You clearly need more funding for healthcare. What are the arguments that you normally put out?
Good afternoon. We know Sven, each other, we know quite a long time, and we know also that there is money outside somewhere. I met a few weeks ago my Lithuanian colleague. He was in Tallinn. And he told that in Lithuania they ended up last year, health insurance fund, ended up with a surplus. And I can't say that they have plenty of money, but it felt like this. And then he said, and then Minister of Defense Lithuania came and said that we will collect all your surplus.
That's the example that you give to Sven?
No. Wait a second.
That's not a good example, Ryan, to get more money.
Johannes, wait a second. And then I asked that, how did it happen that you ended up with a surplus? Because was it wrong budgeting? Because we all are suffering and there is a lack of money. Healthcare has two situations of money. Either there is a little money or no money. And then Gintaras said, well, Ryan, look, economic growth. If you would have economical growth instead of negative growth, then you wouldn't suffer. So my first discussion with Sven is when we are going to change the economy to grow, and then health insurance fund, we are funded by all our taxes, and then we will have little more money, and then we can spend it wisely.
And get even more money?
Johannes, you began the story that which we all know. Good thing is population is aging. Not so good thing is that around those people who are working in the ages of 20s, 30s, this number is decreasing, which means that the moment when we reach there, then all young people who haven't born yet, they have to basically work 4 times harder. That's the challenge, which means that this is not the doubt that we would need in the future more investment to the healthcare. But we need to find a way how to do it. Carmen said her 3 priorities, and we are going to discuss soon what we are going to do and what priorities we see also in health insurance fund.
So Sven, what kind of evidence do you actually need to feel confident that supporting a stable and long-term increase in healthcare funding actually makes sense?
Yeah, I guess it's not a question about growth or whether the growth should be there. Growth is always there if the wages are growing. For example, my first question would be, although the economy is not doing that great, the wage growth has been still quite high. So the revenue from social tax has increased by 50% in the last 5 years. Where did it go? So this would be the first question, but it's of course a simple question, but at first glance, but it's actually more difficult to answer, because if we're talking about structural changes within the budget, within your budget, then there are even more questions. If we're discussing about sustainability, then we can ask the question, how can a system be self-sustainable if large components of your budget are growing faster than the country's average wage? For example, the wage bill of doctors and medical staff. So, if there are no internal balancing factors that roll back the expenditure growth, then there cannot be a sustainable system. So the parallel would be the system, the pension system, right? The pension system was tweaked in a way that there are internal balances that roll back the growth if, for example, the life expectancy increases. So these are the questions that we have, I guess.
You asked a difficult question and then partly answered it yourself.
If I may add,
You
or answer. A little bit looking wider picture, because one thing is economical part, how well we are doing. And this is not a secret or big secret that, that Lithuania is doing better than Estonia last year. Don't worry, we will catch up. We always did. The second part is the fact what we know that the euro or dollar invested to the health promotion and disease prevention will bring you back $7, or the treatment is $7 more expensive. And that starts, I like when Carmen said, it starts from ourselves, because nobody else can change you beside you. And guess what? I'm doing already quite a long time morning exercises, which I hate. I'm the night person. And when I wake up in the morning and see that I need to go to the meeting, but no, I need to do my blank. And this is not easy, those who have done, but keep trying it. And persistence is the key there. Educational part is the key also in healthcare. The more educated people in the country is, the more healthier this country is as well.
I understand. I don't want to bring this drama back, but it does seem that the current funding model no longer allows you to maintain...
We need to change the funding model, fully agree.
Yeah, so the current model no longer allows you to maintain service levels, is that right? So what exactly needs to change?
Okay. In Health Insurance Fund, we are currently preparing the next 4-year strategy or strategical document, our development plans, and there are 3 main parts. Our lifestyle needs to be changed, otherwise we will not survive. And to do that, when we look our primary care, the situation in our primary care when we have roughly 800 GPs, general practitioners, both solo and with working together, 300 out of them are at the retirement age, which means that if we push either too hard, then 6 months later we have 1/3 GPs less. And then we can't handle it anymore. So we need to fix that one. We will try different models. We will use a lot of technology as much as we can, both to make sure that right people, right doctor, or right specialist, right time, etc., as Carmen said, that we are going to use. Second one is priority is the changing the financial model of the healthcare, and we are aiming towards the value-based healthcare, meaning that we need to start measuring way more the health results than we do it right now. We have started several years ago the patient treatment journeys, and where we are measuring the PROMs and PREMs, patients reported outcome measures, patients reported experience measures, and this is only 1.5% out of our whole treatment budget. When I would say that, okay, let's increase this 1.5% to 5% or 10%, then politicians are saying, no, this is a too low goal. But in reality, it's a very ambitious goal. So that is the directions where we need to start moving. And the third part is, which already discussed today, is to fix all the data. Because you cannot make decisions looking the mirrors. What happened in the past, we need to see the future. And currently we have 3 major databases which we must connect, because data is there and legally we cannot check 2 or 3 databases at the same time. We have planned, and luckily there will be a change of law, and then technological part we are going to do ready by the end of, I would say, this next year. And then we see how fast the legal challenges are going to be solved. So these are the 3 things which we are going to do, and of course what Carmen said about quality, that's essential. That's essential thing in healthcare. And that you cannot check if you don't have data. And also quality part, I personally don't think that when you follow all the written steps that you necessarily provide very quality work. You might, but not always. I would love to ask feedback from the customers. I would love to compare the treatment results. And this is where we have room for development.
So, Rain, what you basically said, right now the funding in healthcare is mostly based on volume. Who provides...
Fee for service. And,
fee for service, exactly.
This model doesn't attract the service providers to make necessarily the better work, because if we pay based on volume, then they increase volume.
So how do we make that shift? I mean, clearly no one wants to offer less services without a good carrot to offer those services more effectively and to get, well, a reasonable amount of money in return, Sven. So where do you see that tension, in a way, that this volume-based healthcare financing has, well, brought us today where the system is not, well, capable of continuing in the same path?
Yeah, I guess as I'm not a healthcare expert, I'm not sure how I can discuss about the sort of internal incentives or what incentives work the best within the system. I see more the macro level imbalances. And as I mentioned, this is the question of sustainability, and if you ask me what should we do, then the first question comes to my mind: do we understand the problem, or do we understand it the same way? Have we decomposed the issue of unsustainability? Where does it come from? Are there internal balancing schemes in place, or should there be internal balancing schemes? And of course, you within your sector, you can discuss how to more incentivize the hospitals and the sector to provide better services and perhaps more efficient services. I don't know. But this is, for me, more of a question of results rather than the financing. So looking at from the financing perspective, the first question is, do we understand the problem? Are there internal possibilities to fix it within the system? And then we can arrive at the questions of whether we should invest more in the system to get more social sort of benefits.
So and what you're saying is basically, should we shrink the system?
Not necessarily. I mean, I didn't touch upon the effectiveness of the system in terms of the hospital network, for example. So these are also questions unanswered. What is the impact or possible impact of restructuring the healthcare system in terms of hospitals and in the regions? So this is another unanswered question. So we have to put these puzzle pieces together, and there has been a discussion that a lot of data is available. The data itself doesn't speak. You have to have a narrative, you have to have arguments. The more data you have, the more difficult it becomes to understand what is actually going on. So, and then we arrive at how the budget decisions are made, how the financing is made, and the more data and conflicting data you have, it's much more difficult to actually introduce additional funding to the system, because there are basically there are no clear answers or clear narrative or clear objectives.
Right, you obviously have looked the data very carefully.
Yes, 2 comments. Sven, I agree that data is a key, and we have pretty strong analytics department in Health Insurance Fund. I have to tell you a story, and then you understand better the challenge which we have. Story is very simple. When we looked from the data where the money, where the time disappears. The time disappears when you go to the outpatient meeting, and either GP or the doctor spends 20 minutes is a FaceTime towards patient. And out of 20 minutes, 15 minutes, doctor is typing in a computer and putting the stuff there. And we thought that because I have passion for technology, and we thought that, okay, let's use IT and to get people more time, both doctors and both patients, and then there is a fabulous thing, artificial intelligence. And imagine if AI would make an epicrease instead of doctor. You don't need to type, you will look the patient, and everything looks really fine. We do quick mathematics, okay, we can give you, dear doctors, we can give you 10 minutes time out of 20 minutes appointment. And then as a businessman, we thought that, okay, 10 minutes time, we can multiply all the visits, we can heal all the patients, but demand is endless. And then I had a meeting with the Doctors Society, and I asked the question, what would you do if you would get 10 additional minutes? These are not private doctors. These are government and local municipality owned hospitals mainly. And there were like 200 people. And they almost unanimously said that, thank you, please give us 10 minutes more time. We will use this 10 minutes to talk more to the patient, and if there is no need to talk, then we will use this rest of 3 minutes, 5 minutes, 7 minutes to heal our mental health. And then I realized that, and I asked the same question while I met private doctors. And then we got the answer what we thought or we expected. I will take another patient. And there is a huge difference of mindset of thinking. I'm not saying one is wrong or one is right, but you might think lots of ways how to improve things. Unless you are not piloting or testing or speaking with the audience, then you might be totally wrong. And then we realized that we are totally wrong. We did the project, which idea was to make people's lives easier, that you can do the blood test at your village or your area where you live. You don't need to drive to the hospital. We did this project, and our execution was bad, because hospitals still are saying that you need to come here and you need to give this blood in our hospitals because the payment model is wrong. And unless the payment model is wrong, then they are not going to change because there is no motivation to do that.
So Ryan, how do we change that motivation? I mean, clearly there is not a lot of enthusiasm to go to this outcome-based financing model, right? So what do you do to get them on board?
There are two things. There is always two motivational things.
The stick and the carrot.
Stick and carrot. And we would love to push more on the carrot side, then carrot side, and then carrot side, until we have it, and then we have reached to the limit, and then we need to try also the stick part.
So where are we in this progress?
That is what we are going to do, and this is the first time in my career where I have a minister who really supports. Yes, Rein, you can use stick, because earlier ministers, they were more carrot type.
So where are we in this progress? Do you already have a stick with you in your office and ready to use it? And how will that look like?
Stick is there, but local municipality elections are in October.
Aha. Right. So we're going to see the stick being used after local municipality elections. What will that look like?
That you said, you mentioned, he said, not
yeah,
I.
what will that look like? How will you change the system?
We call it the strategic purchasing program. And that will help us. It includes both decentralizing and centralizing part. But I'm looking the watch, and we don't have time to cover it today.
Very briefly.
In October.
Very briefly, few keywords.
We need to agree with hospitals where we are doing which procedure. That's one keyword. And second one is that simpler services needs to be closer to the people. So, and that corresponds very well to Carmen's statement that, what is the right word, for the health providers network, the right sizing is a right word in English because it includes increasing and decreasing, that's the same word. And also financial model changes, but it takes a little bit the law change, and that's I'm counting on the Ministry of Social Affairs and the Parliament. Because without that one, we will not move too far.
Sven, it's been a long monologue or a brief dialogue between me and Ryan. I would like to bring you back to the panel so that you don't feel awkward and lonely on the stage. It is, yeah. How much are we actually using data to guide us where we invest in healthcare? And are we actually ready to shift our priorities when, let's say, new information becomes available and data shows that, oh, we should actually do things differently?
Yeah, I would start from the fact that there are a couple of windows during a year or during 2 years when these kind of decisions are made, large structural changes within the budget. One of them are the elections or the government changes, the coalition agreements, when things are discussed, hopefully based on data. And the other one is in autumn when we are putting together the state budget, when the Minister of Social Affairs has a floor, she can say whatever she likes. So you have to understand there are only a few points in the time when you can change something. And taking this into account, you better have to have good quality data, a good narrative, a good perspective, strong arguments, good ways of conveying the message. You have to have, the minister should have leverage within her party. The party should have leverage within the coalition. The moon phase has to be right. I have seen like crazy decisions made on crazy data.
It's difficult to control the moon phase, but do we have the data?
Yeah, we try to control the moon phase. We're trying to put the, you know.
Wow, you have a difficult job, but do we have the data?
This was a joke, but this is the question. We at the Ministry of Finance are relying on data provided by different sectors and different ministries. So of course we do not come up with the data, and we are not analyzing everything, but we are always suggesting that the better arguments and more quality you have in the data, the easier it is to overcome the moon phase. or make the wrong decisions harder. Because if you're all over the place, then whatever can happen. But if there's a clear path and determination in terms of changing something, then there is a hope, I would say. But we have seen, of course, in terms of the changes in the budget structure in favor of the health insurance fund a couple of times in like past 10 years. One was the political leverage, like 10 years ago when there was additional funding put into the health insurance fund, and the other was COVID. So if something bad happens, usually it triggers additional funding. So this is also one sort of a trigger point, or you better have to have the data ready.
Well, in order to use this data in a meaningful way, we often face with rather expensive IT investments, right? Now, do we know what kind of efficiency and gains we're actually getting from these investments, or is this picture somewhat vague, Karin?
I respectfully disagree that all the IT investments are very expensive. When I looked at, we have done it not with the massive money there, and still there are plenty of things which are working and which is part of everyday life. Nobody asks questions how much it costs, because it doesn't cost so much. But we are getting immediately notification from the press that if something is under maintenance or doesn't work.
I do that, yeah. I call then your guys and say, why isn't it working?
Yeah. Like digital prescription, which is everyday life, and when this was before we moved cloud, now this is in the public cloud, and I sleep way better. While we did it ourselves, then it was down like 27 minutes, and then next morning I was on the morning TV, and they asked me, should we go back on paper because it's more reliable?
Journalists love drama, yeah. I'm sorry about that, but we do.
So definitely we need to invest more on IT, and I see the supportive council member in the audience who agrees that we need to put more money on IT.
So to do what? I mean, what are the digital systems that you need to make your work and the taxpayers' money, spending it more effective?
I can tell example of the connecting system from patient to the GPs. We call it PADI, the GP's registration system. And in the beginning, it was kind of suspicious part that easier was to call. But when 60 or 70% of GPs started to use it, and people realized that you can type there your challenge, and then this is like a triage that if you have severe situation, then you will be getting access faster. If you just need an advice, then you can wait 3 days, and it has picked up very nicely. And today, plenty of people are thinking, why didn't we use it years ago? But I see the great future, and what I rely is use of AI. Artificial intelligence is not replacing doctors, but can make life way easier, faster and smoother. And those who are not investing there, those are pretty soon living in yesterday.
What do you mean by AI in the healthcare sector in Estonia? What potential do you see?
For example, we are missing people from the radiology area, and those radiologists who are reading the pictures, machine can do it in some certain ways even better. And first pilot will be 2 doctors and AI, second one is doctor and AI, and pretty soon there will be only AI who are looking pictures. There is a legal, typically, I love lawyers, don't get me wrong, but there are legal questions why we are slow in some areas. Plus, connecting data, my best regards to the Data Protection Agency. So this is one of the projects where from the day one they said yes, yes, they are supporting it, and now they can prove it that we can really go fast and realize that project.
Sven.
Yeah, just to add on AI, I think there is an imminent disruption in our way in terms of how we think about data systems, how we think about the software platforms, because quite recently SaaS model was the way to go, to think about it, put everything in the cloud, software as a service. So the projections from ex-CEOs of Google, for example, are that the middle layer of software becomes irrelevant. You only have data and AI that you can ask anything, which means that all these data systems or information systems that do some business processes become eventually irrelevant. So you have to have good quality of data and AI based on the data, and you can do anything. And this is not something in like 5-10 years from now. This is, the projections are like 1 and 2 years. And so we have to be prepared for that, or think how we can use it to our advantage.
We have...
Sven, you know that AI is a very rapidly growing child. And what children do, they sometimes, I can't say they are lying, it's not the right word, but they are inventing something. And AI right now, if it doesn't know the answer, it can easily invent that one, but that is what we need to double check.
Well, we even have stories where children kill their parents, but let's not get into those. Sven, you wanted to add something?
Yeah, just
less dramatic.
Just one sentence from also a Google ex-CEO. I think he said that although we feel that AI is overhyped, he believes it's underhyped actually, because we cannot imagine.
We don't know what it's capable for.
Well, isn't that an interesting discussion to go further into in the remaining 5 minutes we have, where I promised to take some questions from the audience. So let's hopefully spend those 5 minutes with your questions. What about tax reductions for healthy foods, exercise possibilities and education? These things help people keep their health. Sven.
Yeah, sure, there are some tax exemptions in place in terms of healthy life, but usually the tax benefits tend to be inefficient in nature, because every taxpayer puts their funds into the tax incentive, and the people who have more money spend the more amount of these funds. So this is why they're usually inefficient. Of course, the other component is, does it change the price? Because the price is usually market-based, and usually the price don't go down as much as the benefits should suggest. And of course, there are exemptions to that. Some tax exemptions are efficient, but not all of them. Estonia has gone with a way of broad tax base, less incentives to keep the tax base, tax system simple, which has its benefits. But yes, there are some in place already.
What are the specific actions planned or ongoing in the health insurance fund while shifting from volume-based to value-based medicine? Do you have any examples?
Yes, to be balanced, then I will give two. One is a stroke project, and there is a positive results. So those service providers who are working together, they have got extra premium, and based on the results measured proms. That's a good example. Not so good example is the endoprothesis project, where we ended up, we just did it last month. We ended up that more than half of our service providers, they had to pay money back to us. It is kind of disaster, but it's a very educating disaster, because we agreed what should be the expected results. They didn't meet it. Some did, they got money. but majority didn't. They paid us back, and they will change something in their services in favor of patient, because in the end of we are measuring how patient is doing. So yes, we do have examples, good and not so good, and not so good we are learning, hopefully.
Aging, negative demography, conservative immigration limits, internal budget balancing. What concrete new financing sources could be attributed to healthcare? Who knows the answer?
Yeah, well, we in the Ministry of Finance look at the state as a whole, of the public finances as a whole. So the deficit of the health insurance fund is already a deficit of a country for which we borrow funds, right? So it's already within the budget system, and if we balance the total budget, then we are okay as a country, I would say. And then it becomes a question whether we should put funds from one bucket to another to help the health insurance board to get their sort of balance correct, so improve it there, worsen it somewhere else. So in a macro perspective, it's rather a question how large should the tax burden be in Estonia? And this is also a longer debate, I guess. But if we are talking about additional funds, then we should be talking about the new tax or a tax hike in an environment where taxes are already increasing. So
you don't see that coming, in short?
I don't see that coming, not only because there are other priorities like defense for now, and the budget is already in the deficit, and the taxes are already increasing, but also because of these couple of unanswered questions within the health insurance system in terms of financing, and do we understand the issue, and have we done anything within the system to improve the sustainability before we are talking about additional funds.
Sven still has questions, if you've done enough for efficiency, Rain.
We can do better, but you need to compare to the others, and then let's look at these numbers.
It's not only a question to Ryan, it's a question to the Ministry of Social Affairs as well, for example, if we're talking about the hospital network, right? Mm.
And last question from the audience: can the Estonian Health Insurance Fund carrot and stick method be implemented of treatment quality criteria, not rewarding GPs and specialists for activities, but patient adherence and treatment outcome?
Yes, is the answer, and our time was up, but very quick comment, example. Screenings, cancer screenings, and many years we measured, and you know, what you measure, that you will get. We measured the attendance. We got 60%, 70%, 72% of attendance, and we were super happy. This year we are measuring not attendance, but how many cancers we managed to detect in the early stage, and what is going to happen afterwards. So what is the living rate after that one, and we hope that we can save more people doing and measuring that one. That is one of examples. Thank you very, very much.
Thank you very, very much, both of you. Ladies and gentlemen, this is a wrap for this panel. Thank you.